Good evening, everyone. Welcome to my IVF Answers. Welcome to the European Fertility Society. And welcome, everyone. It's great to have you back here. And as you can see, we have our special guest and our presenter for tonight right here with us. Dr. Ángela Llaneza is with us. Hello, Dr. Ángela. Great to have you. How are you feeling tonight?
Hello, good morning. Well, good morning, no, good evening. I'm very happy to be here. Thank you for having me.
Thank you so much for joining. This is your first webinar with my IVF Answers, so I'm glad that you've joined the team. Dr. Llaneza is, of course, from Clinica Tambre. She's the fertility specialist that will be helping us tonight with your questions, but also she has a presentation on our topic. We will discuss poor ovarian responders, as you already know. So, as always, we will start with the presentation on our topic where Dr. Llaneza will explain all those details related to our topic, but afterwards there will be time for your questions, so don't hesitate. We always know that this is your favorite part, so if you have any questions ready, you can put those in the chat during the presentation, but also during the Q&A session. Don't hesitate. This is your time. This is an opportunity for you to simply get some answers that possibly haven't been answered yet. And that's why we are here. And as you know, we are coming here almost every single week just to support you, provide you with various topics. And as you know, tonight we will talk about how can we predict IVF outcome in poor ovarian responders. And I guess I can't wait for the presentation to start. So, Dr. Llaneza, are you ready to start the presentation?
Definitely ready to discuss this fascinating and challenging topic.
Brilliant. Thank you so much. The presentation is right here and we can go ahead.
Well, thank you all for being here. Today's topic is very interesting and very important indeed, because this is one of our main problems, one of the main pathologies we treat every day in our consultations. Low ovarian reserve is a very challenging situation and very, I'd say, frustrating, both for you and for us, because even though there are things we can do to improve your prognosis and the success rates, still science is behind in when it comes to trying to improve the number of available follicles and possible available eggs in the ovaries. So I don't want to really bore you with physiology and how it works. I have a couple of slides, but the reality is that nature and the way in which the body and the ovaries work has changed very, very, very little. We've changed a lot as a society, but the nature still works as it did in the first moments of evolution. We know that there's no production of oocytes once we're born. There's actually one moment in which oocytes are produced, and that takes place during the fetal development, meaning when our mothers were pregnant with us, with with us as fetus, and when the ovaries were microscopic, they were able already to produce million of oocytes. And actually, there are million of oocytes at birth, out of which there will be around 400,000, 600,000 at puberty, once the cycle and the period begins. Obviously, this is a big issue because since we know that there is not a production in the postnatal life, we know that there is only a constant loss that goes on from birth until the menopause. This loss of oocytes is quite slow at the beginning, okay, but we know that it increases dramatically after 35 years of age. This is an issue nowadays, as we're saying, because unfortunately, due to a lack, variety of reasons, women are forced or decide to postpone the age at which they want to start their motherhood project. And obviously, sometimes we need to deal with a situation in which there are not as many possible oocytes, retrievable oocytes in the ovary as we would need to have good prognosis, high success rates during the IVF treatment. Obviously, this process, this oocyte loss, is going to be faster for some women that might even reach what we call a premature ovarian failure, okay, meaning a total loss of menses and lack of follicles in the ovaries, normally earlier than at 40 years of age, okay? And for some women, this process might go slower, meaning that at unexpected ages, especially after 39, 40 years of age, we can see ovaries still with a good number of follicles. You already know, most of you, I imagine, that follicles are those black balls we see on the ultrasound on the ovaries. Those black balls might contain inside the oocyte, okay? So for us, it is very important before starting any IVF treatment to have a clear view of the status in the ovaries and the reproductive potential of those ovaries, okay? That's what we call the ovarian reserve. The ovarian reserve is a concept that helps us to define the reproductive potential of a patient in the context of assisted reproduction, okay? It is very important to highlight that because right now we know that ovarian reserve is not very useful to predict pregnancy rates, okay, but it is very useful to predict the response to the ovarian stimulation. The ovarian stimulation, I imagine most of you already know, is the process that we need to do in order to maximize the number of follicles that will grow in the ovaries. Normally, in a natural menstrual spontaneous during a spontaneous month, during a natural cycle, okay, there's going to be a group of follicles that are going to be recruited, okay, and that might start growing. However, as the month goes by, as the days go by, the nature is going to make things harder for those follicles, and only the most sweet, the best one, the fittest one, is going to be able to survive despite those harder hormonal and that tougher environment, okay? That's the reason for which on a natural cycle there's only one normally oocyte that is released, but we know that there are many follicles that potentially could be recruited, and that's the rationale for the ovarian stimulation. We're going to create most favorable conditions, okay, to allow all those follicles that we see on the baseline ultrasound, okay, to continue growing. Actually, what we're doing is saving those follicles from their destiny, which would be what we call atresia, okay, the death of the follicles. And I say that because it is very important to know there's a lot of false information, myths around ovarian stimulation. Ovarian stimulation is not going to trigger an early menopause or to trigger an early loss of follicles, okay? Because actually we are only recruiting and using what otherwise would be lost, okay? So as I was saying, it is very important before beginning the IVF process and the ovarian stimulation to have an idea, at least, of how many oocytes we could have at the end, because you know that oocytes are the first step, okay? And potentially more oocytes could mean more embryos at the end of the culture the culture process. Okay, so we always want to have a clear idea and study the ovarian reserve before starting the treatment. There are two ways to study the ovarian reserve. First one is through a blood test to study the anti-Mullerian hormone, the MH, okay? And the second one, those are the most accepted ones nowadays, is in a transvaginal ultrasound scan, okay? Ideally, in the first days of the menstrual bleeding, okay? To see both ovaries and count how many follicles are there, okay? Normally, we talk about a norm, or we say there is a normal ovarian reserve when we have an MH level higher than 1.1 nanogram, okay, per milliliter, or we see between 6 to 10 follicles, okay? If we see a normal AMH level and we see a normal follicle count, we can presume that our patient is going to have a normal response to the ovarian stimulation, which would mean that potentially we could retrieve or have at the end between 10 to 15 oocytes. Okay, that's the normal value. Obviously, there's also the other side of the spectrum, which would be high ovarian reserve, which would mean that we could expect a high ovarian response to the stimulation, more than 15 oocytes. This is not the topic that we're going to address today, but I just wanted to give you this information, okay? As we were saying at the beginning, today we're focusing on low ovarian reserve. I say once again that this is one of the most challenging situations we face nowadays, okay? Low ovarian reserve is a situation in which the reproductive potential might be diminished due to a decrease in the number of remaining follicles in the ovary, and hence less possible, a lower number of oocytes that could potentially be retrieved, okay? We say that there's a low ovarian reserve when the MH level is below 5.5 picomoles or 1.1 nanograms, okay? Both units are used indistinctly, okay? Depends on the country, depends on the lab as well. So I'm giving you both numbers, okay? And also when the follicle count is below 5, okay? There's another there are some other criteria, okay, to diagnose the low ovarian reserve and let's say describe and classify our patients, okay, taking into account some other parameters, okay. This is what we call the Poseidon classification, okay. And here we would separate our patients according to the age, more than 30 or less than 35, okay. And we would also take into account a past response, a previous response in a previous IVF cycle, okay. I can say that when in an IVF cycle, an ovarian stimulation cycle, when the medical treatment has been correct with enough dosages of gonadotropins, the medication that we use, in spite of that, we also we have
Dr. Llaneza, just give us a second because right now the sound is really bad. It's breaking. So can you try to turn off your camera? Sometimes it helps.
see what we can to try to improve the sound.
Okay, now it sounds better. I hope that it helped already.
Is it better?
It's breaking. Let's try and switch off the
Is it
camera.
sounding better now?
Now it's okay, but just in case, if I say to you that the sound is breaking, just let's try and switch off the camera. That should help a bit. Okay? Can you hear me now? Can you hear me? Can you hear me? Okay. Oh, okay. Just let's give it a minute. Okay, I don't think Dr. Llaneza can hear me. You can hear me. Okay, because we cannot hear you. So I'm not sure if you switched off your microphone by any chance or... Okay, I think that's best if you can log in and log out and log in once again, just in case, all right? Let's try that. I think that will help. Because we cannot hear you right now. Sorry, guys. Let's give it a second, okay? Let's try to fix it, and I'm sure it's going to be okay. Let's make sure that you can hear Dr. Llaneza properly. Let's wait, okay? I'm sure she'll be back. Yes, thank you for your comments. I think that there was an issue with the connection, but I know that Dr. Llaneza is trying at the moment to reconnect. So hopefully it's going to be all okay. And she's back, so just let's give it a minute. Okay, let us know if you can hear me already. Okay.
Hello, Caroline.
I can hear you now. Yeah, we can continue. Now it's better. Let's go ahead. Thank you.
So you're welcome. Sorry, thank you for letting me know. So as I was saying, there is some other classification method, which is what we call Poseidon criteria, which also includes the age above or below 35 years of age, and also past response to past cycle of ovarian stimulation. If the patient has collected less than 4 eggs, or if the patient has had a suboptimal, what we call a suboptimal response, meaning having collected between 4 to 9 eggs. Okay, this is a different criteria, probably the most used one right now for us, but it's also, I think it's important that you can also have this information, because sometimes when you come to our consultation, we are specialized in complex cases. It's something that we address on our first consultation, when you've done a cycle, an IVF cycle elsewhere, and we are not so pleased about the ovarian response despite having had used enough dosage of medication. Okay. When we face a low ovarian reserve, as I was saying, we frown a little bit. We are concerned, because having a low ovarian reserve means that most likely the response to the ovarian stimulation will be low. A low ovarian response is having less than 4 oocytes, being 4, 3, 2, 1, or 0. 0 because despite using the medication, there is not follicular growth, or because even though there's growth in the follicles and they grow, we get to the oocyte retrieval and no oocytes are collected. Okay, so it's something that is worrisome, because as we said at the beginning, the first step to have embryos is oocytes, And the more oocytes we will have, the more chances and the more embryos we could have at the end of the embryo culture. You know that nowadays we always do the blastocyst culture, okay? Ideally, that should be the norm everywhere, but not everybody does that. But we want our embryos to develop until the blastocyst stage, because that is going to allow us to really strong one embryos that have made it through a very tough natural and lab selection process, okay? There's something that I wanted to tell you that I always tell my patients during the consultation. Age does make a difference. So far, there's a lot of ongoing discussion, okay? We don't really know the causes behind the low ovarian reserve. We know that it's something probably physiological. After 40 years of age, we know that there's going to be a reduced number of follicles in the ovaries. We do not know why that process takes place at earlier stages for some patients and later in life for some other patients. But if there are no chromosomal abnormalities or genetic abnormalities that are found that could explain that low ovarian reserve, there's still an ongoing discussion, as I was saying, but we know that most likely the oocyte quality is not going to be impaired, meaning that we can expect those oocytes, once fertilized, to produce embryos with the expected implantation potential that normally is attributed to age. We know that the main prognostic factors for an IVF treatment right now are those: age, the oocyte's age, and the number of eggs, the ovarian reserve, that we are going to work with. Obviously, it is not the same to have a low number of oocytes. Here we can see those curves, each correspond to an age, okay? So we're going to work with, for example, less than 35 years old of age, okay? And 44. So for example, for a 50% probability of having at least one live birth, okay? This study is fantastic. It comes from the United States. It was published in 2017, and actually we do not have anything more accurate right now to predict the live birth rate, okay? But for example, if the patient is 35 or less than 35 years of age, with 10 oocytes, okay, we could have more than a 50% chances of having at least one live birth. Whereas if we were in the same situation, if the patient is 44 years of age, to reach a 50% live birth rate, you see that the amount of eggs that we should retrieve is unreachable, okay? Obviously, these are just statistics, populational, okay? They talk about the population. They do not tell us about what is going to happen to you, but it's a reference we use, very useful one, to guide you in the decision process, whether to go ahead with an IVF treatment in certain situations or not, and also to adjust our expectations. The thing is that right now, in almost everything that we do in reproductive medicine, we are not able to know beforehand what is going to be your result, okay? We can give you ideas, we can give you success rates, but we cannot say exactly what is going to be your situation. We do not know if one oocyte retrieved in a woman at 43 is going to produce a euploid embryo that will be embryo to implant, that only one oocyte retrieved. And we do not know if 3
euploid embryos obtained from oocytes from a woman who's 36 will produce a pregnancy. So actually, there are many things that we need to take into account before going ahead with the process, and also before not doing something, okay, just based on statistics, okay. Statistics are always 0% or 100% if something happens to you, but actually we do not know whether that's going to be the good one or not, or when we will have the good oocyte. Will it be on the first stimulation? Will it be on the second stimulation? We do not know, okay. But as I said, it's a challenging situation, and obviously we want to help you. Obviously, we always want to do our best to maximize our chances. And as I said, right now, there's nothing we can do to take the time back to refill those ovaries with follicles and with oocytes. There's a lot of research going on because it's a very important issue, not only for us, but for many scientifics, but from different fields, not only medicine. But there's nothing we can do to improve, for sure, the situation in the ovaries. Each extra oocyte makes a difference, and we try to improve the response to the stimulation, but always our expectations need to be very realistic, okay? It is true that depending on the type of treatment we do, on the type of protocol we do, on the type of medication we use, on the experience of your doctor, on the experience of the lab where they're going to decumulate, fertilize, or even froze those eggs to undergo an egg freezing process or an egg accumulation process before reaching a good number to fertilize them and undergo the embryo culture process, okay. But an experienced medical team and an experienced lab with cutting-edge technology are very important. It's very also important, I'd say, to stay up to date to the scientific knowledge. And there I would add that it's also very important to be honest with our patients, not to discourage you, because obviously we know, and you know sometimes even better than us, that the situation is tough, that the chances are low, but we need to tell you where we are so we can fight together and understand the results that we might have. And obviously, also in relationship to what I was saying, it is very important to treat low ovarian reserve patients as one. Each case is different. Each patient is different. As we always say in medicine when we are students and our teachers tell us, or some teachers, in medicine there are not diseases. We have patients who might have a disease. So that means that we need to treat you as an individual with a specific situations, and each ovary is going to respond differently. And we also know that even if we do the same protocol twice in the same women, the result is going to be different. Obviously, the ovarian reserve markers, the DMH and the antral follicle count, give us a range within we might expect to move when it comes to the number of eggs, but maybe one protocol might yield one oocyte and the next one might yield 3. We never know, okay. We never know, but obviously experience here makes a difference. The technology at the lab makes a difference. The experience from the embryologist makes a difference. And we need to use everything we can to add some more oocytes to to the collection, to the egg retrieval eventually. Okay, I think that by using up-to-date, individualized protocols, normally on average we might be able to add 1, 2 supplementary oocytes. I'm always very realistic and very honest to you. We do not do miracles. There isn't any single protocol, preparation, vitamin that is going to make you go from having 2 oocytes to having 10. That would be unrealistic. But each extra oocyte counts, okay? There are many different types of preparations. That's beyond of the scope of this conversation. Obviously, later on during the questions and answers, I would be more than happy to answer maybe more specific questions on this topic, supplements, vitamins, type of endometrial protocols, etc. But knowledge and the lab does make a difference. Okay, so be aware that if you're a patient who's suffering from a low ovarian reserve, if you doubt, if you hesitate about the protocol or the expectations that you are being given, never hesitate to ask for a second opinion, even if eventually you do not do the treatment with a specific center. But there are many very good and I'd say experienced fertility centers everywhere. Obviously, I cannot neglect the fact that Spain is a superpower when it comes to reproductive medicine. Probably that's the only thing in which Spain is a superpower, but we need to say so about reproductive medicine. And there are many talented professionals that everywhere, France, Germany, Italy. So if you are not sure about how you're being treated, etc., do not hesitate and ask for a second opinion. Okay. So just before we go to the questions and answers, which is the part that I'm most looking forward to, my take-home message is that do not be discouraged before talking to a specialist. Knowledge, the experience of the center does make a difference, okay, when it comes to the number of potential eggs that we could retrieve. Do not get fooled because unfortunately there are many people out there trying to make a business out of reproductive medicine and who are not so honest in their intentions, and they promise miracle treatments, which I insist do not exist nowadays. There's nothing we can do to dramatically increase the number of available follicles and oocytes, potential oocytes in the ovaries. And age does make a difference, okay? So if you have a low ovarian reserve, if you know of someone who has a low ovarian reserve, please do not hesitate to contact a renowned center. Please do not hesitate to tell that acquaintance, that friend, to get in touch with someone serious and able to help you with the latest knowledge and the latest technology. Okay. And well, that would be everything from me. Now is the best part. It's your turn. Thank you so much for your attention. I hope that most of the ideas were clear. I'm open for questions and discussing. And there you have our email, okay, information@clinicatambre.com, okay, where my colleagues will be more than glad to help you and provide you with assistance if necessary.
Brilliant. Thank you so much, Dr. Llaneza, for your explanation to our topic, and of course for presentation, thorough presentation and thorough explanation of what you can expect. And of course, right now, your favorite time, as we already said, Q&A session is about to start. So if you have any questions, go ahead, type those in. There are some questions ready. I will be showing you the questions here in the chat. And let me start with the first one here. So can you explain to us how is AMH measured? Is it an absolute value based on the blood sample provided or extrapolated to the weight of the person? I'm asking because I accidentally gave my clinic the wrong weight.
So actually, the weight itself does not play a role. Okay, the weight does play a role when it comes to the nuance, the adjustment of the dosage, and it is true that initially that the AMH, the measurement of the AMH in picomole was especially pushed forward to be used for a specific gonadotropin whose dosage is calculated by introducing the patient's weight. Okay, but don't worry, because it shouldn't mean anything, or it will not change the value of the MH.
Brilliant. Thank you so much for your first question and explanation. And let's have a look. There are some questions here from Edie. If you have premature ovarian failure, can you take DHEA? What dosage?
Okay, so here there's something that I want to clarify. Okay, we talk about premature ovarian failure when the patient has already gone into amenorrhea, into menopause. Okay, which is a clinical diagnosis. There's a lot of misunderstanding, even between gynecologists, between premature ovarian failure, meaning early menopause, and low ovarian reserve. Okay, so DHEA might be useful to treat some symptoms related to premature ovarian failure, okay, to early menopause. But the advised treatment is hormonal replacement therapy, or the contraceptive pill in some cases. Okay, and when it comes to DHEA and its utility to improve the ovarian reserve, so far it is not proven. Okay, it is not proven whether it might help or not to increase the ovarian reserve. The recommended dosage should be between 50 75 milligrams a day. It might even improve the oocyte quality, but I insist that it is not proven. And normally, considering that it's something cheap, over the counter, with no normally no side effects, okay, I'm very fond of it, and I always advise you to use it. Okay, we stop it once we start the ovarian stimulation, and if not, we change it to the active form, which is testosterone. Okay, but I insist that there's no clear evidence, scientific evidence behind that.
Crystal clear. Thank you so much. And of course, there's a follow-up here as well. If you have premature ovarian failure, is it better to do a light natural IVF?
This is a very controversial topic. I'm not a big fan of natural IVF. I think that if we are going to go for a medical treatment, we need to, at least at the beginning, try the most accepted strategy, which is an ovarian stimulation with gonadotropins. Obviously, we can reduce the dose, reduce the cost by using oral drugs, clomiphene, letrozole, okay? But the thing is that we know that many cycles naturally might be anovulatory, meaning that we won't have an oocyte, and making a patient undergo a follow-up, monitoring ultrasounds, and potentially retrieval under sedation, because we do the retrievals under sedation with a low likelihood of having an oocyte, is not an option. Obviously, this kind of situations out of the norm, okay, need to be discussed together in the consultation, and we decide on a case-to-case basis.
Okay, again, Thank you so much. I hope that helped. And let's have a look. More questions are coming in. Let's take a look at the next one. So I'm from Ethiopia. My wife AMH result is 16 per nanograms per liter, and all FSH, LH, histosalpinography results are normal, but still there is no menstruation till the age is 26. What shall we do?
Probably here we are on the other side of the spectrum. An MH higher than 16 nanograms points towards a high ovarian reserve. In this situation, that's very compatible with polycystic ovaries, which is a situation in which we know there's an ovulation and in some cases even amenorrhea. So my advice is to go to a gynecologist to get a in-depth assessment. Also, there are many exams. We do general hormone profiles and try to see if actually the reason is the polycystic ovaries. In that situation, what we do normally, the treatment, we try to improve the situation with metformin. If it's also important to control the weight. There are many endocrinological issues behind, and normally if we know that the menstruation is not coming because the cycles are anovulatory, meaning that an oocyte is not being released, one of the classical treatments was trying to help those ovaries recruit a follicle, release an oocyte, and then sustain the luteal phase after the ovulation.
Right. Again, thank you so much for your advice. Again, hope that helped. If you have any follow-ups, you know what to do. Let's have a look at this question. So you mentioned that to diagnose someone with low ovarian reserve, you look at AMH and follicles. Which is more important, or are they both just as important?
To me, they are both just as important. It is not very clear which one weighs more, okay, whether the AMH or the follicles. When we're going to begin the ovarian stimulation, I mostly focus on the follicles, okay, but the AMH is there. So what happens sometimes is maybe, especially when we have a good stimulation where we fortunately get to recruit more follicles than what we expected, and eventually we come to the retrieval and still despite that we get a low number of eggs. There you have the MH1 playing a negative role. Right now it is not very clear which one of those weighs more. From some internal research we've done, probably AMH could be more important. But normally we trust more the follicles.
All right. Again, brilliant. Thank you so much. More questions are coming in. Let's see the next one right here. So are there specific things that you would advise to help with ovarian response in those with endometriosis and low ovarian reserve? Can the HEA make endometriosis worse?
Okay, so at the end of the day, what we have endometriosis, we know that is a disease that is going to affect fertility in two ways. One of them is and the most accepted one is by damaging the ovaries when they are ovarian cysts or endometriotic lesions in the ovaries that are going to damage the healthy ovarian tissue. If what we want, if possible, is to improve the the environment that endometriosis creates, which might be more unfavorable to, I'd say, especially implantation, not so much the ovarian reserve. We treat the ovarian reserve by doing those protocols. Right now, there is not one single protocol more specific to endometriosis that has proven to actually be better. You know that nowadays the treatment of the endometriosis lesions, the endometriomes in the ovaries, is as a norm, not advised. Okay, it is not advised to remove the endometriotic cyst in the ovaries except in certain situations. And actually, it's a good theme, a good question, very clever question that you ask. Can DHEA make endometriosis worse? We do not know. Okay, we know that endometriosis obviously is a disease that has many sides: immunological, hormonal, inflammatory. But when it comes to the hormonal situation, we know that there's an excess of estrogens, and right now there are some research published, latest research published, that tell us that maybe in endometriosis it does not tell us so much about DHA, but about maybe trying to keep those estrogen levels lower than the average during the ovarian stimulation, to try to improve the response. I hope that helped answer your question.
Thank you again, Maya. Thanks for your question, and I do believe it was helpful. There was a follow-up from our previous patient regarding the high AMH, right? This is the patient. So also metformin was, I guess, his wife is allergic to it. Gynecological evaluation is also normal. All fine, all by finding. Yeah. Anything else you could advise here?
Hopefully, I cannot help you in the distance. I cannot help you without even having had seen your wife and the blood test and a gynecological assessment. There are alternatives to metformin, but it's also that corresponds to endocrinologists to try to let's say use different drugs with whom with which they have a larger experience. There are some complements such as inositol, coenzyme Q10, vitamins derived from the group B group vitamins, okay, that are said to possibly be helpful in the PCOS, in the ovarian polycystic syndrome, okay, or with polycystic ovaries, but still it is not proven. We know that improvements in the way of life, changes in the food, increasing the aerobic exercise to 30 minutes a day of fast walking might help. But behind those high AMH levels, there's always some kind of hormonal imbalance that needs to be tested.
Okay, again, thank you a lot for that. And let's have a look, okay? Next question we have is, my question is on PRP. Does ovarian rejuvenation with this help increasing the AFC? Also, what's your experience with DHEA, CoQ10, other supplements?
Okay, so to start with PRP, which is now trending topic in fertility, promising. Okay, we know, for those of you who are not familiar with PRP, is platelet-rich plasma. Okay, we take a blood sample from the patient. We process that sample. We leave the platelets. The platelets are very rich in growth factors, molecules that might wake the tissues in which they are, we release them, okay? And it has been said that these molecules, these growth factors might wake dormant follicles, okay? So far, this has not been proven, okay? So it is very important to say that it is an experimental technique. Frankly, I don't like talking about ovarian rejuvenation because I don't think right now that is not possible. PRP is still experimental, okay? So obviously we are trying to do it in selected cases. The good thing is that we know that mostly is something harmless. The blood comes from the patient, so there is not going to be a reject. We are going to put it inside the ovaries on the same procedure or separately, even though we rather do it on the same procedure, on the same egg retrieval. Okay, so we would be using the same sedation, the same function of the ovaries. The risk of the possibility of complications is very low, but it is something that it is not and probably won't be useful to all of the patients. From what we know, if some patients could benefit from this technique, probably that would be patients younger than 40, because as I said at the beginning, right now, there's no way we can get time back in the ovaries, neither to improve the quality, neither to improve the quantity. And my experience on supplements, DHEA, as I said, I use it. I'm very fond of the estrogens, of androgens, such as DHEA, testosterone in most of the patients, but there are some patients that will not benefit from that. Coenzyme Q10 and other supplements. So far, no supplement has been proven to improve the ovarian reserve. So we need to be aware of that. But we know that they are not harmful. Okay, they are expensive, some of them. So we need to be aware that there is no evidence behind. But trying to find a balance. Sometimes I do that kind of pre-treatments with supplements that could potentially help to improve the oocyte quality, but I insist it has not been proven.
Okay, again, thank you for an interesting question indeed and for your answer. There's a follow-up. Okay, so what volume of PRP you inject in each ovary?
Actually, you got me on that, because I don't really remember the volume right now. I cannot tell you.
Of course, that's okay, perfectly okay. So thanks a lot, of course. There are some questions left, so if you have more, go ahead, type this in. This will be like the final call for those questions. Now we will go to this question from Raquel. What IMH is ideal in a 33, 35-year-old to have a great retrieval?
I would ask a different question. What is a great retrieval? So for a normal purpose, I said when we undergo an ovarian stimulation, the ideal number of eggs we want to have is probably 15, maximum between 15 to 20. But even though it was possible, we don't want to get behind that number of 20, because we know that at the end of the day, the pregnancy rates will not improve. Okay, so probably I'd say between around 15, maximum 20. Okay, and depends on the patient, the weight, etc. But normally, I think that an AMH level between 2 to 4, which can be expected at that time, could help us get to that number. Obviously, as I always say, okay, AMH, antral follicle count are markers. Okay, they give us an idea, but until we do not get to the real situation in which we give those gonadotropins to the ovaries, like the fuel to a machine, we do not know what the real response will be. But with an AMH between 2 to 4 nanograms, okay, it is pretty likely that we will reach that number of at least 15x that we want to have good success rates.
Thank you so much indeed. Let's have a look. Now we will have a bit of a longer question with some of those details right here. So let's give it a second. It's quite a long one. I'm 43, went from AMH 0.5 1 month ago to 0.2 last week. I'm underdoing dual stim. First retrieval 150 units, gonal F 225, menopause, dual trigger ovitriol 2 shots, decapeptyl 2 shots, gave 4 mature eggs, 4 follicles, 2 fertilized, 1 made it to day 3, the other one was pushed to day 6 in order to do PGTA testing but stopped developing. Second stimulation, day 8, only 2 small follicles despite increasing treatment. I'm losing hope of even getting 1 embryo to test. What can you tell about my case? Is there any chance of more follicles to appear, or those 2 to get mature enough to proceed to retrieval? If so, when do you think it could happen? My doctor said probably on the 29th of May, but wasn't sure. Could the drop in the AMH be the reason of poor response in the second stimulation? I heard follicular stimulation usually work better though, but it doesn't seem to be the case here.
It's a tricky question because in order to answer you, I need to tell you things about the stimulation that you're doing. Well, I wouldn't be doing this type of protocol, and there are some details that are missing. It is true that right now there is not a clear protocol that works best in any case, and not even for a dual stimulation. But well, when it comes to, let's focus on the first retrieval. If you had 4 out of 4 follicles, 4 eggs, and 4 mature eggs, excellent, because it's a 100% result, so very good. 2 fertilized, still 50%, so well, not bad. So they had, I imagine, did they freeze an embryo on day 3? Weird. And the other embryo was pushed to day 6, but obviously the embryo did not made it and was not suitable for biopsy. So well, there we have the probably that tell us about the egg quality. Okay, that is a bit impaired. The fact that out of 2 fertilized eggs, none of them eventually made it into a suitable embryo for biopsy. Normally, if the blastocyst does make it to the embryo does make it to the blastocyst stage, and it is usable, it is because it has good quality, and in most of the cases the embryo will be suitable for biopsy. So here in the first stimulation, the result, we always need a little bit of luck. You weren't very lucky, but also there's the quality issue behind. And with how the first stimulation, the follicular phase stimulation was designed with the menopause and the dual trigger, I don't really like using those drugs on the first stimulation, on the follicular phase stimulation, on the first stimulation, because we know that maybe it is not proven, but it might impair the response in the luteal phase, the second stimulation. So far, no response. We need to be patient, okay, because we know that the second stimulation, the luteal phase stimulation, might be 1 to 2 days longer. I would push it to maybe 10 days, but if still you have only 2 small follicles, I would cancel this cycle and have a discussion with you in the consultation. And I think probably your doctor will do the same. I'm losing hope of even getting 1 embryo to test. Well, if this is your first stimulation, there are things that can be done medically, things that can be improved or changed. So there's still something we need to do. Probably you were already aware of the chances before going ahead with the treatment, and you had hope. So if I'm telling you that there are things that can be changed and still tried, I think a new stimulation could be feasible. Is there any chance? No, we already discussed that. I don't know. I cannot tell you when the retrieval will take place. Sorry. We never know when we will have the good embryo. But overall, your chances, considering what I can see and the results you're giving me, are less than 10%. But if you still wanted to try, and this was your first stimulation, there were still some things that we could try. We could still try, I'm gonna say.
Okay, thank you, Claire, for your detailed question. I hope that helped again. And let's have a look. Okay, here 2 parts. Is it safe to do double stimulation before retrieval in hope of greater amount of eggs at retrieval after having failed cycle?
It's safe to double stimulation before retrieval?
Yep.
Do you mean increasing, doubling the dose of the stimulation, of the doubling the dose of the gonadotropins, Raquel?
Yeah, let us know. I think she's right.
I cannot see the answer.
Not yet. Someone is typing, so I believe that's Raquel. So let's give it a second. Yes, yeah, that's what she means.
Increasing 2 times the dosage?
I believe so, yeah.
Okay. No, it won't change anything. I mean, right now we know that using more than 300 units, international units of gonadotropins, it is of no use. And going from 300 to 600 before the retrieval will only make you spend more money for probably nothing.
Okay.
After having paid the cycle, I insist that for most of the patients, there are some patients for which higher dosages up to 450 might be useful, but as a general idea, using more than 300 international units of gonadotropin is useless.
Okay, thank you so much for clarification. Raquel, again, I believe that was helpful. If you have any follow-ups, perhaps there is there is one right here. So is it better to repeat with the same dose then?
Depends on the medication that was used, and depends on your overall situation that I do not know. If it's your first stimulation, you had 2 follicles and it was a blank function, meaning that we know sites where the follicles were empty. It's something that can happen. I would, in those cases, I always try to do a different protocol, trying to improve what can be improved.
Okay, thank you so much again for that. There are like 3 questions left. We'll be finishing. Let's have a look. Daphne has another question. My doctor has also recommended DHEA, so glad to hear that you use it too when appropriate. How long do you recommend taking it for? And is the evidence unclear both in terms of egg quantity and quality?
Yeah, evidence is unclear on both things, quantity and quality. I advise you to use DHEA at least for 1 month. But if we were to work as the ovaries work, probably 3 months would be the ideal time.
All right. Thank you. And there's a thank you from Raquel from the previous patient.
Thank you. Yes.
Let's see. The question is from Maya. Do you prefer to use FSH only or FSH plus LH in stims for those with low ovarian reserve? Do you ever use high doses? I've had a high dose and had 4 follicles, 3 mature eggs, 3 good quality blastocysts. Afraid to reduce dose in case don't get as many eggs, but worried higher dose may actually be a problem, as lots of specialists don't like using high doses.
As I said, there is for a certain type of patients for which 450 international units is going to be better than using 300 international units with a specific drug medication. In your case, frankly, 4 follicles, 3 mature eggs, 3 good quality blasts. Actually, if I was your doctor, I wouldn't change anything because you had a very good result. So I would stick to that one because the result was pretty good.
Okay, brilliant. Thank you so much.
You're
Possibly welcome. Our final question. Let's see. Lastly, comparing short protocol and antagonist, right? In women with low ovarian reserve, which of these 2 do you have a better oocyte yield?
None of them has been proven to be better than the other. It is true that in patients with low ovarian reserve, we find some hormonal imbalances at the beginning of stimulation that need to be treated. So as long as we take care of those, which can be addressed either with an antagonist protocol or a long protocol or an ultra flare protocol, it is good. But when it comes to the number of eggs that we will get at the end, I insist no protocol has proven to be better than the other.
Okay. Again, thank you so much. Hope
You're
that
welcome.
helped. And as I mentioned, it seems that that was our final question. However, remember that if you wish to ask some more questions, you can get in touch with Clinica Tambre's team. I'm sure they will be happy to help you. And as always, I know doctors require a little bit more details, so go ahead, get in touch with them. The email address is in the chat as well. Thank you so much, Dr. Llaneza. Thank you for joining us tonight. This is your first one, but I think it was really great to have you here, and I'm looking forward to our next webinar, which is coming actually quite soon.
Yes.
Before we finish, anything else you wish to add? As you can see, lots of comments are coming up right here.
Thank you to every one of you. I hope that was helpful. It's hard to help you not seeing you as patients, but I hope at least you had some clear ideas, so nobody can fool you, which is very important, because there are a lot of people trying to benefit from the low ovarian reserve and fooling our patients. And looking forward to talking to you again. And it was great being here tonight. I enjoyed the questions. Thank you so much.
I'm glad that you mentioned that, because I just want to mention that actually next week on Tuesday at 7 p.m. UK time, again, we will be back. We will discuss, sorry, this is not the topic we will discuss. This is the topic we discussed today, but the next topic is PGTA indication prospects. So you can join us. You can already register for our topic. This is going to happen next week, same time. So thank you so much, everyone. Remember, it has been recorded, so it will be uploaded on our YouTube channel tomorrow, and of course on our website, My IVF Answers. Our guest, Dr. Ángela Llaneza, was here, and I'm glad that we will see each other next week, same time. Thank you so much for your time. Thank you for joining. Thank you for your questions. Enjoy your evening, and of course, see you very soon. Dr. Llaneza, thank you so much, and see you next week. Okay.
Likewise. Thank you. Have a nice evening. Bye
Take
bye.
care.
Thanks.
Bye.